Thank you very much for spending the time with us here on the COVID-19 respiratory support session. My name is Gavin Perkins and I'm a Professor of Critical Care Medicine at Warwick Medical School and University Hospitals Birmingham. I'm going to be talking to you today about non-invasive support, the different options. In terms of declaring conflicts of interest, I have no commercial conflicts of interest to declare, but I need to share with you that I've received funding from the National Institute for Health Research to conduct a randomised controlled trial of non-invasive ventilation strategies in COVID-19, the Recovery Respiratory Support Trial. Anything that I say during the course of the presentation are my own views as opposed to those funding the research, the Department of Health or Social Care. This is a great session and we've got a really good lineup of speakers today where we're going to really start to focus and spend some time looking at the role that non-invasive ventilatory support may play in providing a therapy for COVID-19. You'll see from the lineup of speakers that we've got some of the world's best experts presenting on topics of their key areas of expertise and evidence. My role in this presentation is to give an overview of non-invasive respiratory support and the different options. And I plan to do that by touching on the epidemiology of COVID-19, the requirement for us to consider alternatives to invasive ventilation, and then just provide a high-level overview of some of the evidence informing that has led to the development of international clinical guidelines to support the use of non-invasive ventilation options. I don't need to remind this audience, a group of critical care and emergency clinicians from around the world, of the devastating effect that COVID-19 has had on our communities that we serve. With the first descriptions occurring just at the turn of the year, we've seen a substantial increase in the number of people affected by COVID-19 and the catastrophic effects that's had in terms of critical care provision to people severely affected by COVID-19. The WHO, in their latest data downloaded today, the 27th of August, reports 23 million cases globally, of which there have been 800,000 deaths, really having a substantial global impact on our community's health. People will be familiar that the majority of people that develop COVID-19 develop a mild to moderate illness and can actually self-care in the community, with only between about 10 and 20% of people requiring hospitalisation for more severe forms of ARDS, of which approximately 15% require oxygen therapy for the development of acute respiratory distress syndrome linked to COVID-19. Amongst the overall cohort, about 1 in 20 patients will develop severe respiratory failure, mandating admission to intensive care and consideration of invasive ventilation. And it's the context of that large scale and large number of people developing COVID-19, of which, albeit only a small proportion become critically ill, that has led to an exponential requirement for the provision of critical care worldwide. And in many cases, this has overwhelmed capacity. Whilst healthcare systems have tried to increase capacity, this has often lagged behind the clinical need. In the UK setting, and indeed internationally, we've seen many healthcare systems need to expand their hospital capabilities. This is one of several COVID hospitals that were set up in the United Kingdom in preparation for a substantial surge of COVID-19. Such was the concern of the overwhelming the existing healthcare system. The UK government set up the Ventilator Challenge, where they challenged manufacturers in record time to start manufacturing ventilators in anticipation of there being an overwhelming demand that would exceed our capacity. It's in this context that, of course, one needs to consider alternatives to invasive mechanical ventilation, which, of course, would be our mainstay of treatment for patients affected by severe ARDS, and to start to consider alternative strategies such as non-invasive ventilation strategies. These exist in a variety of forms, ranging from the provision of non-invasive respiratory support through a face mask, either in the form of continuous positive airway pressure or bi-level ventilatory support. Those modalities can also be delivered via a helmet. There's also the opportunity to provide high flow nasal oxygenation to similarly provide non-invasive respiratory support to those on the borderline of needing invasive ventilation. There are a number of advantages and also potential disadvantages to the use of these technologies in patients with severe ARDS caused by COVID-19. And again, thinking about the talks that are coming up in the course of this session, I'm not going to go into detail of each of the interventions and modalities, as these will be covered in much more detail shortly. But looking overall, the advantages potentially for non-invasive strategy are the opportunity to avoid the need for sedation. It allows patients to remain conscious and cooperative in their care. Through reducing the work of breathing, it can potentially reduce self-induced lung injury, and the requirement for critical care facilities and nurse-to-patient ratios may be less, providing non-invasive ventilation technologies. And also the equipment is generally simpler and quicker to use, and if looking to manufacture at scale, easier to manufacture at scale. Of course, with advantages come disadvantages. Not all patients will be compliant with treatment. Many can report that it's claustrophobic or difficult to communicate. There's a risk of participants or patients developing pressure ulcers associated with the use of these devices. Incorrectly adjusted devices also raise the risk of gastroinsufflation and potentially causing vomiting. Paradoxically, misapplied and inappropriate settings can lead to an increase in self-induced ventilator lung injury through excessive tidal volumes, resulting in volutrauma and barotrauma. In the UK, we've seen challenges with oxygen flow and infrastructure failure, and we have a talk coming up in this series around the potential risk of aerosol generation associated with these technologies. I'm going to look now in two contexts for the scientific evidence underpinning the use of these strategies. This is a network meta-analysis from Toronto that came out in JAMA a short time ago, looking at the use of helmet non-invasive ventilation, face mask non-invasive ventilation, standard oxygen therapy, and high flow nasal oxygenation. It looked at randomized controlled trials focusing on all-cause mortality and intubation. And whilst at face value in this forest plot, one can see low and moderate certainty evidence that compared to standard oxygen therapy, the use of these technologies potentially reduce all-cause mortality and the risk of intubation. But looking into this, as the authors did in the series of sensitivity analyses, there are certain subgroups where the treatment effect is modulated. And so if one, for example, focuses on patients with more severe impairment of oxygenation, then the effect of face mask versus standard oxygen therapy is no longer significant. Similarly, removing patients that have conditions known to benefit from non-invasive ventilation, such as congestive heart failure and acute exacerbations of COPD, the effect on face mask versus standard oxygen therapy and high flow oxygen therapy versus standard oxygen therapy similarly reduces. Of course, we have our own experience from the LungSafe trial in Europe, which was a large prospective observational study which demonstrated that non-invasive ventilation was used in 15% of ARDS cases, but was associated with a high failure rate. And amongst those where they failed attempts with non-invasive ventilation, there was an associated high mortality. And looking at the cohort as a whole, non-invasive ventilation use in moderate to severe ARDS was independently associated with increased mortality. So moving on then to look at the use of non-invasive ventilation strategies, I commend this living systematic review again from the Toronto group, looking at the use of non-invasive ventilation strategies in patients with coronavirus related disease, including COVID-19. And you can see in the table here that the only study reporting, so I'm just going to start this this slide again if I can, because I've not articulated it in the way that I want to. So I'm going to pause. I'll go back to the previous slide and then I'll move forward. So moving on to focus on this systematic review and summary, again from Toronto, looking at the use of non-invasive ventilation technology in the setting of coronavirus, including COVID-19. One can see a range of impacts, with the main study reporters suggesting a potential signal of harm for patients with COVID-19, and then smaller studies covering MERS and SARS, potentially, or at least suggesting that the treatment may be safe and effective. If one then looks to the translation of these research into clinical practice guidelines, given the heterogeneity of settings, it's perhaps not unsurprising that there's heterogeneity in the interpretation of the evidence. So the ANZIC groups support and recommend high flow nasal, as does the Surviving Sepsis campaign. In the UK context, we recommend against the use of high flow nasal oxygenation in the absence of there being definitive data around its effectiveness and concerns in relation to the risk of infection and spread. The British Thoracic Society guidelines support the role of CPAP in the setting that intensive care facilities are overwhelmed. So bringing us to the towards the end of the presentation, one is looking again. Sorry, I'm going to start this slide again. So I've just moved back to this side. In the UK context, we've initiated the Recovery Respiratory Support Trial in order to evaluate the safety and effectiveness of CPAP versus high flow oxygen versus standard oxygen therapy in the context of patients with COVID-related respiratory failure. The trial, which is still active and running, has a primary outcome of the need for ventilation, or mortality within 30 days of randomization. And we're very keen to receive any interest and support on participation in the trial. So to summarize, I think COVID-19 has had a significant impact on the delivery of critical care that has required us to think about new and potentially innovative ways of treating patients with severe respiratory failure. And I hope over the course of the remainder of this session, the insights from some of the world experts will hopefully place the use of these ventilation strategies into the correct context. Thank you very much for your time and attention.